Hello everyone. So today we will be learning about community-based health insurance in India. As we move ahead, we will learn what is health insurance and what is the history of health insurance and community-based health insurance. Then we will briefly look upon the current Indian health scenario. Then we will learn about the definition of community-based health insurance and how does it work and how it is different from the government or private for-profit health insurance schemes. Then we will look at the three types of community-based health insurance schemes. And finally, we will look upon some of the CBHI schemes running in India and Bihar. And we will end it with learning about the challenges related to the community-based health insurance. So let's start. So what is health insurance? Health insurance is defined by the as according to the Health Insurance Association of America as a coverage that provides for the payments of benefits as a result of sickness or injury. It includes insurance for losses from accident, medical expense, disability, or accidental death and dismemberment. And why do we need health insurance? Because health insurance can help us to avoid the stress and financial strain that can come with unexpected illnesses and injuries. So, if we look at the history of health insurance, the health insurance sector in India is only a few decades old. However, it has deep roots in the traces and the writings of Manusmriti, Dharmashastra, and Arthashastra, where it is mentioned that how pooling of resources was helpful during calamities like floods, fire, and epidemics as early as 200 BCE to CE 200 CE. So, the first health insurance concept was first suggested by Hugh the Elder Chamberlain from Peter Chamberlain family in 1694, and as a result of which, by the 19th century, accident assurance began to be available. And from the middle to late 20th century saw the traditional disability assurance, they evolved into new health insurance programs. And if we look at the India, in the last 50 years, India has shown a huge development in the field of health insurance. So in India, the first health insurance was launched in 1948 with the Employees State Insurance Scheme, which served as an umbrella of social security for the blue collar workers of the organized sector. As we know that this ESIS scheme is still prevailing and it is being run by the contribution from the employers and employees. After that, in 1954, the central government health scheme was launched, and which again is a contributory scheme and it caters to the needs of central government employees and their families and provides comprehensive healthcare services to them. Then, in 1986, the Mediclaim policy was launched by the General Insurance Corporation to standardize the terms and conditions related to the insurance companies. And this was a voluntary health insurance with the which provided all the healthcare related expenses, excluding with few exclusions. After that, in 1999, there occurred a privatization of the health insurance schemes, and so that led to the launching and of the Insurance Regulatory and Development Authority of India Act in 1999. And if you look at the history of community-based health insurance, so it can be traced to as early as 18th century, when during the Industrial Revolution, workers' unions were developed, and these workers' unions they formed their own insurance mechanisms. And in India, the CBHI scheme was first launched in 1952 in Kolkata, West Bengal, which comes with the name of Students' Health Home, which I will be discussing later. Now, let's see the current health scenario of India. So, we can see from the graph that government health expenditure share in the country's total GDP increased from 1.13% in 2014-2015 to 1.84% in 2021 to 2022 and to 1.9% in 2023-24. And major commitment of the National Health Policy 2017 is raising the public health expenditure progressively to 2.5% of the GDP by 2025. So we are currently at 1.9%, and the aim is to achieve 2.5% by this year. Also, if you look at the total health expenditure, so in the total health expenditure of the country between 2014-15 and 2021-22, the share of the government health expenditure has increased from 29% to 48%. And the share of the out-of-pocket expenditure in the total health expenditure has declined from 62.6% to 39.4%. Now, what is this out of pocket expenditure? So, basically, this out of pocket expenditure is any direct outlay by households, including gratuities and in kind payments, which is given to the healthcare practitioners and suppliers of pharmaceuticals, therapeutic appliances, and other goods and services, whose primary intent is to contribute to the restoration or enhancement of the health status of the individuals or population groups. And here, the total health expenditure actually includes both the public and private healthcare spending. And this government health expenditure is only including the public healthcare spending. Also, if you look at the NFHS 5 data, so 41% of the households in India have at least one member covered by a health insurance or financing scheme, including both public and private. Now, before moving into the definition of community-based health insurance, so actually there are three different types of health insurance. It can be broadly classified. So first is the government-sponsored schemes or the social health insurance, like we have Ayushman Bharat and Ayushman Bharat Health Scheme. Okay, Pradhan Mantri Ayushman Bharat Health Scheme. Then we have the CGHS, which I have said, and ESIS, Employee State Insurance Schemes. And for the private, for profit health insurance schemes, we have various schemes which are run by private companies. A few of the examples like Aditya Birla Health Insurance, etc. And the third is this community-based health insurance. So it is different from both of them because here it is not for profit insurance scheme. And the other two insurance, that is the government and the private, they are mostly focused on the formal sector or the organized sector, whereas this community-based health insurance is more focused on the informal or the organized in unorganized sector. So let's look at the definition of community-based health insurance. So it is defined as any not-for-profit insurance scheme that is aimed primarily at the informal sector and formed on the basis of a collective pooling of health risk and in which the members participate in its management. So it offers a potential to reach low and middle income populations through existing community-based organizations such as non-government organizations, self-help groups, cooperatives, microfinance institutions, and trade unions. So how does this CBHI work? So the CBHI schemes, they involve prepayment and the pooling of resources to cover the cost of health related events, and the targeted community is involved in defining the contribution level and collecting mechanisms, as well as the content of the benefit package and allocating the scheme's financial resources. So every member of the CBHI scheme has a say in the scheme. Then the membership is almost always voluntary rather than mandatory. So that's how it is different from both the government and private for profit sponsored health schemes, health insurance schemes. So now we will look at the types of health pay community-based health insurance schemes. So type 1 is also known as a provider model or the health maintenance organization design. And type 2 is the insurer design. And type 3 is the intermediate design. So let's look at each one of them, one by one. So type 1 CBHI, also known as the provider model. Here, as we can see from the figure, here the healthcare, actually the community is giving the premium to the provider. The provider is the NGO or the health maintenance organization, and also the insurer. So here the health insurance, the NGO running this insurance scheme is also the healthcare provider. They are also providing the care. So, for example, the voluntary health services in Chennai, which is running a medical aid plan under which households pay an annual premium, which is graded according to joint monthly income, directly to the VHS, and in return, they are provided with a free annual health checkup and discounted rates on outpatient and inpatient services. So here what is happening is health maintenance organization type schemes in which members pay premiums to the provider and are in return entitled to outpatient and inpatient services without any additional charge or at discounted rates. Now, if you look at the type 2 CBHI or insurer models, so actually there are several NGO owned schemes. These are known as NGO owned schemes. So here the NGO is the insurer, but it does not provide the healthcare itself. It is providing the fees to the healthcare, and the healthcare provider is a third party, payer arrangement. So this is also known as third party payer arrangement because the community is paying the premium to the NGO, which is the insurer, and the healthcare provider is different, was providing the healthcare to the community. So one of the, very good example is Yashaswini Trust of Bangalore, Karnataka. So what they are doing is Yashaswini Trust is the NGO or the insurer, and the healthcare provider here, it is the Narayan Hridayalaya group of hospitals, which is providing excellent care to the community. So I will be discussing the premium and benefits and exclusion criteria related to the Yashaswini Trust later. So here, if we look, the members enroll in this type of scheme, they pay the premiums to the NGO and are in return reimbursed for the expenses incurred by them in availing services from a predefined provider network. So this is also known as a mutual model, where the risk involved in providing insurance cover is retained by the NGO. And if you look at the type 3 CBHI model, it is also known as intermediate model or the linked model or the partner agent model. Why? Because here, now several of the schemes they involve here, the NGO is acting as an intermediary between the target community or the population and one of the general insurance corporation subsidiaries. So one of the good example is this, Self-Employed Women's Association of Gujarat. So it is an NGO intermediate scheme. So here uh, they are linked. This association, this NGO is linked to the National Insurance Company, and this Seva's most popular policy is a premium of rupees 85 is paid by the women for life, health, and assets insurance, and an additional rupees 55 can be paid for insurance for her husband. Rupees 20 per member is then paid to the National Insurance Company, which provides coverage to a maximum of rupees 2000 per person per year. So this is a partner agent model where the insurer develops the insurance products and underwrites the risk, and the agent in this case is the NGO as responsible for selling, distributing, and servicing the products. So this is recognized by the Insurance Regulatory and Development Authority of India. Now, moving on to the CBHI schemes in India. So, uh, first, I will be discussing regarding the schemes, which is covering both the outpatient and inpatient care. And then we will look at the schemes which is covering only the inpatient care in India. So, first is the Students' Health Home, which is also the first CBHI scheme to be launched in India. And here, uh, if you see, this is a provider-owned scheme, and the target population is a full-time student in West Bengal state from class 5 to university level. So this scheme is actually, if you look, it is built by the blood of the students and youth. If you look at it was established in 1952 with the spirit to bear all the burden of ailing students through a self-help movement of entire student community. And we can compare the rate charts of services in students health home. So this is for the student member and this is for the general public. So as we can see, there is no admission charge, admission advance. Admission charge is only rupees 75 is against rupees 300 for the general public. Then bed charge is also rupees 30 as against the general public, which is rupees 750. Then attendance charge is also nil If we see the consultation fees, they are also nil. So this is how it is working. And the premium is rupees 4, which is taken in the schools. Now coming to the Yashaswini Trust Bangalore, Karnataka 2003, it was when it was launched. So the target population here is the members of the farmer cooperative societies in Karnataka, and they are providing an annual premium per client was recently increased from rupees 60 to rupees 120. They are providing free doctor consultations, drugs, and hospital stays at nominal rates. And this scheme covers more than 1,600 surgeries. Maximum coverage is provided for one person per year, amounts to rupees 2 lakh. And the only exclusion is inpatient admission without surgery. Then another is this Raigarh Ambikapur Health Association in Jashpur, Chhattisgarh, which was established in 1974, and it is NGO owned. So the target population here are the poor people living in the catchment area of the 92 rural health centers and hostel students. So, and the premium here can be paid in rice, and the benefit they are providing is free outpatient care, and after paying an initial entrance fee, members receive free hospital care up to rupees 1,000. And the Sevagram Sorghum Health Scheme of Vardha, Maharashtra, which was established in 1978. It is a provider-owned scheme, and the target population is they are the residents of 40 villages. For a village to be included, at least 75% of households should be enrolled voluntarily. Yeah, should be enrolled, and it is a voluntary. Everything is voluntary here. So, and the premium is rupees 48 per landless household, up to 5 people, or can be paid by 15 kg of jowar. Additional fees for land owning households के लिए. Then benefit is 50% coverage of OPD visits and planned hospitalizations, including normal deliveries, and 100% coverage for emergencies and unplanned hospitalizations. Hospitalizations must be at a single teaching hospital. Then the VHS Medical Aid Plan, Chennai, Tamil Nadu, which I have earlier discussed. It is a provider-owned scheme and it was established in 1963. So the target population here is anyone may join, voluntary individual. Yeah, anyone may join. So there is no target population, specific target population, anyone may join. And you can see that the premium that they are providing is, I already told that it is membership fee is graded according to monthly income. And the benefit that they are providing is free annual health checkup, curative and diagnostic services for outpatient and inpatient services at discounted rates. Now let's see some of the CVHI schemes covering inpatient care only. So this is the Accord scheme, which is Action for Community Organization, Rehabilitation and Development in Nilgiris, Tamil Nadu, established in 1988, and it is a Type 3 model, which is linked model, NGO intermediated with GIC as insurer. It is linked with the New India Assurance Company. So here the target population is the Adivasi Sangam. So it is Adivasi Sangam of like people from 300 villages. They are member of this, and age 6 months to 70 years of age. And the premium they are paying is rupees 20 per person per year. And benefit they are getting is all hospitalizations to a maximum of rupees 1,500. It covers care at one trust hospital or others if referral required. An exclusion is only 2 admissions for delivery covered per women. So this is just a snippet from their website, Adivasi Munnetra Sangha. So currently, like you can see, with over 1,000 Adivasis in participation, this pivotal movement signaled the end of an era of suppression and fear and paved the way for social justice and self-reliance. So another one is Kadamalai Kalanjiya Vattara Sangam, Madurai, Tamil Nadu, KKVS in short. It was established in 2000 and it is NGO owned, which is type 2 model, insurer model. So here the target population is women members of self-help groups and their families aged 12 months to 55 years. It excludes those with a history of chronic history. And premium is rupees 150 if the coverage is for a family including the self-help group member and at least one other beneficiary, and rupees 100 if coverage is only for the member. And benefit is reimbursement of 75% of hospital expenses up to rupees 10,000 per family per year, except in an emergency. Benefit only for treatment at Kadamalai Kundu Hospital. An exclusion is must be an inpatient for at least 48 hours, no coverage of pre-existing disease, and nor normal delivery. And this is another, working women's forum in Chennai, Tamil Nadu, which was established in 2001 to 2. It is NGO intermediated with Royal Sundaram as an insurer, so it is Type 3 model. And target population is women members of the WWF and their families. The premium for children is rupees 65 per year, and for adults less than 45 years, it is rupees 125 per year, and for more than 45 years, it is rupees 175 per year. The benefit includes inpatient expenses up to rupees 7,000 per year, maximum rupees 5,000 per claim, and it limits maternity care to rupees 3,000, cataract to rupees 2,000, and bed charges rupees 100 per day. And this self-employed women's association, which I have already discussed, so it is in Ahmedabad, Gujarat, and it was established in 1992, which with NGO intermediated with GIC as insurer. So here the target population is self-employed women and their spouses aged 19 to 58 years, and the premium is individual coverage rupees 20 per annum, and also membership can be paid by fixed deposit. The benefit includes inpatient cost, private or public hospital to rupees 2,000, and fixed deposit members receive one-time flat payment for maternity care, dentures, and hearing aid. An exclusion is normal delivery, pre-existing diseases, more than one hospitalization for newly developed chronic disease, HIV/AIDS, and its complications, diseases resulting from drug or alcohol use. So this is a portal of the Seva. We can see that 3.2 million members are currently enrolled across 18 states in India. So in Seva, they believe in the power of inclusivity and oneness. Now for Bihar, it was very difficult to find the data regarding the community-based health schemes, but I could only find this, microinsurance academy. So what happened was that in 2007, the Sarvajan Unnati Bodhini was established as a charitable trust in New Delhi, India, under the Indian Trust Act to advance the development of microinsurance. So to achieve this, Sarvajan Unnati Bodhini created this microinsurance academy as its implementing body. Now, this microinsurance academy launched the Swasthya Kamal scheme in Vaishali district in 34 villages in Mahua block. So, because Vaishali is prone to waterlogging and floods, and this academy found that communities do not perceive climate-related risk in isolation if there is a flood. It not only affects health issues, but it also impacts crop yield, livestock, and additional risk categories. So, in this project, the this academy that linked climate change with the priorities of the target population to develop customized solutions covering composite risk. And field partners for this project included Nidan and Vaishali Area Small Farmers Workers Association, which is VASPA in Vaishali district, Bihar. Now, before ending, let's look at the challenges related to the community-based health insurance. So the main pitfall or the challenge is, on developing community-based health insurance is finding an appropriate provider. So as we know that the Indian private health sector is unregulated and unaccountable. So in this context, introducing health insurance can lead to uncontrolled cost escalation without the promise of quality healthcare. So it becomes imperative that while considering community health insurance, one should seriously consider mechanisms to introduce measures for cost containment, assuring quality, and ensuring standard treatment practices. So, and this is where the community-based organization or the NGO can play a crucial role by countering the power of the providers. So the CBO could negotiate with the providers and they can develop a package that is conducive both for the patients and the CHI. Yet another issue is the legality of this scheme. So, given the new Insurance Act, IRDA Act of 1999, so currently this act does not acknowledge the presence of these schemes and their role in the larger insurance market. So, this could also be the reason why many of the newer schemes have linked up with the formal insurance companies to legitimize their activity. But in this process, they may have lost on the flexibility and innovations which is necessary for a successful CHI or community based health insurance. And the third one, other issue that needs to be addressed is that of financial sustainability. The very fact that many of the CBHI schemes have been operational for more than a decade itself is proof that it may be a sustainable form of health financing, right? But while accurate financial data about these schemes were not, available, but rough estimates show that they are able to raise about 60 to 100% of their resources. So this has important policy implications as it gives an indication towards the amount subsidy required to make these schemes viable. And given the fact that most of these schemes target the poor, it is important that the government comes forward to subsidize this equitable health financing mechanism. So to conclude, this community-based health insurance could be an interim strategy to finance the healthcare of the people. What is required is to regulate the providers and to legislate so that the community health insurance programs find a space within the Indian insurance context. These are the references. You can go through all the papers. They are very good articles. Thank you.